Hi, everybody. This is Dr. Brett Talley Daniel, MD, and I'm a headache doctor and a neurologist. Podcast today is on an interesting subject. Are triptans safe to take during pregnancy? So triptans, there's 7 of them, are the main drugs used for acute therapy of migraine. So since 1990, triptans are the best acute therapy drugs for treating migraine. And there are currently 7 drugs. And when taken early in the course of migraine headache, 80% of patients may be headache-free in 2 hours, and there's nothing else that comes close to that. Triptans block the release of the inflammatory neurochemicals that come out during the migraine process, but must be taken early in the course of headache development. They should be taken at the onset of the migraine headache or at the onset of an hour if it occurs before the headache comes. What are the contraindications for triptans? Triptans should not be used with a personal or strong family history of coronary artery disease. People have had heart attacks or have angina. They should not be used with uncontrolled hypertension. Doses should be limited for children and the elderly, and patients with basilar artery or complicated migraine or ARA symptoms over 60 minutes. And they should not be triptans mixed with DHE or ergotamine within 24 hours. What are the side effects of triptans? Well, common side effects are chest tightness or pressure, near fainting, neck and back pain, which may be burning, a warm or hot feeling, dizziness, or drowsiness. Now, on my webpage, drmigraine.com, if you'll click acute migraine therapy, I have this article there, and I have a list of all the common triptans written down there. Now, the side effects that come from triptans are usually not serious and are usually related to activation of the autonomic nervous system, which can cause contraction of smooth muscle in the chest, resulting in the tightness. They can either do the trachea or the esophagus, and that causes neck or back pain. Adrenaline release may cause a warm or hot feeling or dizziness. And to me, the important thing about the side effects are that they're not serious and they are dose-related. For example, a person taking a common 100 milligrams Imatrix, which is sumatriptan tablet, may develop chest tightness, but it'll still give her the headache. But if they break the tablet in half and use 50 milligrams many times, the side effect doesn't occur, and usually the lower dose may effectively treat the migraine. The first triptan to come out was injectable Imatrix, sumatriptan, 6 milligram subcutaneously, which is still the best, the strongest, and the fastest dose for treating migraine. But the next dose released was the 25 milligram oral tablet, which had an indication at the time for treating adults, but now would be considered to be a pediatric dose. The other point here is that the headache literature says that changing to another triptan, there's 7, is successful 60% of the time. So if the patient develops a side effect with sumatriptan, rizatriptan or something else may work with no side effects. Next, I discuss the migraine timing cycle, which is in this article. It's a picture that shows all of this, but there are 4 steps in the migraine process, which I like to call the migraine timing cycle. And the first step is trigeminal inflammation by the brainstem. Then the second step, at 20-40 minutes, the ganglia, the nerve, and the artery of the brain start to release the neuropeptides, neurokinin A, substance P, and CGRP. Then in about 2 hours, the release of chemicals causes the third step, which is meningeal artery vasodilatation, and the fourth step occurs at 3 to 4 hours, which is inflammation of the thalamus. And that's a deep nucleus in the center of the brain, which is called the pain center of the brain. The fourth step is also called central sensitization because steps 1, 2, and 3 occur inside the skull, but they're outside the brain. Those are trigeminal nerve. It's an artery and a ganglion of cerebral arteries. Whereas step 4 inflames the thalamus, which is a deep nucleus inside the brain. Migraine is defined by the International Classification of Headache as lasting 4 to 72 hours, and this is done not for some trivial, abstract, academic reason using 3 days or 72 hours is the time a migraine might last, but rather because that's how long these inflammatory neuropeptides stay in the body. They come in the brain, they drain down the veins to the liver, and then they're discharged in the toilet after 3 days. So if one treats migraine with over-the-counter drugs like Advil, Tylenol, they don't stop the release of neuropeptides and the inflammation, yet triptans will do that. That's why they're such important and effective drugs for treating migraine. Patients with migraine should treat with triptans, but never with opiate drugs or drugs of butalbital like Fioricet. Butalbital is a barbiturate drug and is, in my opinion, the worst drug in the world, and it causes medication of use headache, and because of that, it's been banned in every country in the world except in Canada and the United States. Caffeine, Tylenol, Advil, Aleve, and triptans can cause medication of use headache if they're taken too much. The general rule of migraine patients to prevent medication of use headaches is to limit over-the-counter painkillers and triptans to no more than 2 days a week. Medication of use headache is the current term for persons who have chronic migraine from overuse of medication. It used to be called rebound headache, which is an old term. Chronic migraine is defined by the International Classification of Headache as being 15 headache days or more per month, 8 of which have migraine features, and episodic headache is defined as 14 or less headache days per month. If the patient uses over-the-counter medications or triptan, a transition occurs so that after several migraine headaches have occurred within a week or two, every time the patient takes caffeine or Tylenol or a triptan, the inflammatory neurochemicals are released and they stay in the body for 3 more days, and so the migraine process becomes continuous. It's sort of like putting lighter fluid on a fire, which makes the fire continue to burn. If one considers that migraine can generate chemicals that last 3 days and multiply that by 2 days, the result would be 6 days of neurochemical release per week. So if a doctor allowed his patient to take Tylenol or triptan 3 days a week, that's 3 times 3, 9 days with chemical inflammation, more than the 7 days a week. It explains the limitation of all painkillers and triptans to no more than 2 days a week. I have a more thorough discussion of the migraine timing cycle on my webpage at www.drmigraine.com/blog/categories, general migraine. However, this timing cycle point is the reason why migraine should be treated early with a triptan, because the patient only has about 20 to 40 minutes after the onset of pain before the neurochemicals are released, and triptan drugs block the release of these chemicals. It's just that simple. Most patients don't know to treat early, and therefore the chemicals are released and inflame the trigeminal nerve, the arteries, and the thalamus. The patient returns and states that the triptan doesn't work. It's reported that triptans will help migraine headache any time during a migraine, even if it's treated late. But unless migraine is treated at onset and early, the patient will not be headache-free within 2 hours. And headache-free here means that all migraine symptoms are gone: the headache, nausea, sensitivity to sound and light, odors, mental cloudiness. In my office, I go over and over again this point with patients to treat early, and the next time they come in, they report they did well with the triptan. The migraine was gone early. Many patients tell me they get relief within 15 or 20 minutes after treatment, which is less than the reported time it takes the drug to work. So, are triptans safe to take during pregnancy? Yes, triptans have been studied extensively during pregnancy. The answer is that triptans are safe to take during pregnancy. We didn't know that until recently. They have no major teratogenic, that is, baby-harming effects, and most of the data is obtained on sumatriptan. Information regarding sumatriptan is the most abundant because it was first triptan of all the 7 triptans that are now available, and it's been available for many years. And sumatriptan is the best insurance-covered drug of all the triptans, and the price is right. Pregnancy registered data are available for 3 triptans: sumatriptan, niratriptan, and rizatriptan. Related questions: are there reliable research articles showing that triptans are safe during pregnancy? Well, Schaefer et al. Published an article, quote, "Pregnancy Outcome After Anti-Migraine Triptan Use, a Prospective Observational Cohort Study in Cephalalgia," that's a headache journal, in 2018. This article was highlighted at the American Headache Society meeting in 2017. David Dodick, the former editor of Cephalalgia and professor in neurology at the Mayo Clinic in Scottsdale, said regarding the Schaefer article, and I quote, "There has been some mixed literature suggesting that triptans can cause low birth weight infants, spontaneous abortion, and preterm labor, but at least in this study, which was a carefully conducted prospective study, there was no evidence of that," end of quotes. So it's common to use triptans in women who are of childbearing age, and since 50% of pregnancy are unplanned, fetal exposure to triptans is common. Dr. Elizabeth Loader, who's a professor in neurology at the Harvard Medical School and chief Division of Headache and Pain Department of Neurology at Brigham and Williams Hospital, Boston, Massachusetts, who moderated the American Headache session, said the Schaefer findings were reassuring with some caveats. And she said, I quote, "It's nice to see another study that provides information on the safety of triptans when being used during pregnancy." Dr. Loader told Medscape Medical News, quote, "The point estimate for fetal malformations following pregnancy exposure was not elevated, although the confidence interval is wide and some elevation of risk cannot be completely excluded based on this study alone," she noted. However, data from other sources are consistent with the finding, Dr. Loader said. A quote again, "For example, the sumatriptan pregnancy register that was maintained by Glaxo following the introduction of sumatriptan likewise did not show any strong signal of teratogenicity, although the confidence interval could not completely exclude some elevation of risk," end quote. Taken as a whole, she said, this is good news for women who need to treat severe migraine during pregnancy. Another article, Marchenko et al. Reported in Headache in 2015 on pregnancy outcome following prenatal exposure to triptan medications, a meta-analysis, and they found, quote, "The use of triptans during pregnancy does not appear to increase rates for major congenital malformations or prematurity, but may increase rates of spontaneous miscarriage, according to a meta-analysis of 6 studies, including 4,208 triptan-exposed pregnancy and 1.5 million controls." That's a lot of data. Compared with women with migraine who did not use triptans during pregnancy, triptan use was not associated with increased rates of major congenital malformations, prematurity, or miscarriage. As of this date, which is March 2020, 3 published prospective comparative studies confirmed that there was no increased risk of major malformations reported with exposure to sumatriptan during pregnancy. Also, 2 subsequent subsystemic reviews also found no association between teratogenicity and the use of a triptan during pregnancy. There was a large Norwegian mother and child cohort study evaluated fetal outcomes following exposure to triptans during pregnancies. The author identified 1,535 pregnant women who received triptans during their pregnancy. 90% of the women used triptans in the first trimester, and 65% used them during the second or third trimesters. Well, how should pregnant women first treat their migraines anyway? They're non-pharmacologic measures. Everybody knows this. And they should be tried first. They usually work, and their effects on pregnancy are certainly benign. These include relaxation techniques, adequate sleep duration, stress management, massage, adequate hydration, use of ice packs on the head, neck, and shoulders. All the headache literature has ads in there on ice packs. I see those all the time. Avoidance of known migraine triggers, such as heat, stress, sleep deprivation, missed meals, and strong odors. Don't get into your triggers. And then there's simple pharmacologic treatment. This is usually taking Tylenol, which is acetaminophen, which is the initial preferred drug because of its lack of teratogenic effects and general obstetrician doctor approval. However, it may not be effective, and it's less risky to use a triptan during a migraine than to have a pregnant woman who is nauseated, repeatedly vomits for days, becomes dehydrated and deconditioned by long stays in bed with severe migraine and sensitive to light and sound. Therefore, many women with severe migraine are treated with triptans during pregnancy because they are, and this is my last little note here, they are the best drugs for acute therapy for migraine. All right, I'll stop here. Please click subscribe. Thanks for listening. God bless all you women, men, and men with migraine. I'll see you again on another podcast.